So this is the special video on COVID-19. So COVID-19 is the name of the disease. The virus itself is called SARS coronavirus 2 because it's very closely related to the original SARS. It emerged from China in late 2019, and patient zero, or the first person who was known to have what we now call COVID-19, reported their symptoms on December 1st of 2019. The first diagnosed case in the United States, I believe, was in Washington in late January, so January 20th of 2020. There are two countries that have said they've never had COVID, North Korea and Turkmenistan. Lies. Everybody's got it. So this is the most recent data I was able to pull. The US has declared that it has had the most cases in the world. In terms of population, the US is far behind places like China and India, which both have over 1 billion people. I think India's numbers are probably low because of people who live more in isolated villages. I think China's numbers are low because I think China probably has fibbed a little bit about their numbers. Our numbers, I would imagine, are pretty accurate. If you're looking at, approximately 90 million people almost who have had COVID in the US, that's at least a quarter of the population. I imagine that we all know people who've had COVID. So I think we can probably say that that's fairly accurate. In the US, we've had approximately 1 million deaths. And then if we look at our vaccination rate, total vaccine doses administered per 100 in the population, you see it's 178. That's because we're looking at people who've gotten multiple doses. People fully vaccinated, now we're about 67% of the population is fully vaccinated. About 31% of the population in the US is fully boosted. So when you compare to countries like France and Germany, even the UK, which have, of course, smaller populations, but in terms of economics, pretty similar economic status, you see their vaccination rate and their boosted rate is far higher than ours, even though the UK doesn't have a reported boosted rate. Again, this is the most recent data that I pulled from the CDC just for this course. We are averaging 125,000 new cases a day. So this is even more recent data. We're even closer to 90 million now. 347 deaths per day. That's pretty flat. Hospitalizations up almost 6,200. You can see again, the trend is going high. And here's our first booster dose. So about a third of the population has had a first booster dose. So I think we've all heard it on the news. Cases are going up. The new variants are more contagious, but less virulent, which if you're a virus is a pretty good strategy because you want to spread. And if you kill your host too quickly, you don't get a chance to spread from person to person. If we look at community levels in California, Fresno County is highlighted here, but you can see that the majority of California is in this orange color, which means we have high community spread of COVID. There are a handful of counties on the far eastern border and kind of up here along the upper coast areas where community spread is medium. One county in the state has low community spread. So it's not gone away. So people say, oh, COVID's over. COVID's not over. I was actually in a meeting. I work with a group doing teacher training in Egypt, and the Egyptian government is telling them we don't have COVID in Egypt. So they're saying we have no COVID in Egypt, which again, is probably not accurate. COVID is everywhere. It is what it is. Here's our Fresno County data. Again, we have high community transmission. So for every 100,000 people, about 407 have COVID. If we scale that up to the county itself, we have about 1 million people that live in Fresno County. So times 10, about 4,000 people are currently infected with COVID in Fresno County. New hospital admissions, so of that 100,000, about 18, 19 are going to the hospital. We scale it up by 10. That means there's about 186 hospitalized people, new hospital admissions in the county. Of the hospital beds in Fresno County, 11.5% have COVID positive patients. This is much lower than it used to be during the peak of the more virulent strains of COVID, but this affects a lot. I had twins last fall, and you weren't allowed visitors, so I couldn't have any visitors. You could only have like your one support person, masks all the time. If somebody's sick with COVID or sick with something else, the visitor policy is very strict. So it's one of those things where maybe it doesn't affect you because you think you're young and healthy and, who cares? If you get COVID, you'll be fine. But think about how it affects others in the population. And it's one of those things where with public health, it's the same thing that people talk about vaccinations. Well, I don't want to get vaccinated, or I don't want to vaccinate my kids. You vaccinate your kids and protect them. And that's fine. You can say that all you want. But the idea with public health is that we try to protect the public. So we do what's best for the public. And what's best for the public is to stay home when you feel sick, wear a mask if you're out in public. If you don't want to wear a mask, make sure you stay away from other people. Don't judge people who do want to wear a mask. Get vaccinated and protect yourself. All of those like common sense things. Wash your hands, regardless of whether or not we're talking about COVID or any other type of infection. So really what we try to think about with public health is it's not just about protecting you, it's about protecting your whole community. It's about being a good community member. This data is about the different variants that are currently spreading or being identified in the US population. So you might remember, gosh, how long has it been now? Maybe 6 months, maybe beginning of this year, late last year. The Delta variant was very, very common, and you can see now that the Delta is in orange, has not even really shown up on this graph that goes back to April. Instead, all of the different strains are varieties of Omicron. And again, you can see the different lineages of Omicron. What are the differences? There's going to be some differences in the RNA sequence, which leads to differences in the proteins they encode. And so these variations in the proteins they encode can sometimes be what leads to higher levels of contagion or more infectivity, but decreased virulence. And with RNA viruses, we do tend to see higher rates of mutation because RNA replication is slightly more error prone. What are our common symptoms? This is from last year from the World Health Organization for Delta, but the symptoms are relatively similar for all of the different variants or strains. Fever, cough, fatigue, potential loss of taste or smell, potential diarrhea, headaches, sore throat, aches and pains, conjunctivitis, which is like redness in the eyes. I was reading about Omicron. They were saying that more patients are experiencing things like cough and sore throat. And sore throat didn't used to be one of the more common symptoms of COVID. It was like the loss of taste or smell or the cough. But instead, people are experiencing sore throat. They may not even get the cough. So they thought, oh, it's just a cold or, allergies or whatever, but it actually could be COVID. People infected with COVID, any of the variants, this says Delta, but also including Omicron, could be asymptomatic, meaning they may not show any symptoms. This image here is a study from patients who were followed after 1 year of being diagnosed with COVID, and the symptoms they had. And so the majority of symptoms that people are going to report are going to be things like sore throat, runny nose, headache, loss of taste or smell. That's shown here in this image. And you see, 90-something% of patients who were experiencing COVID symptoms, like when they were first diagnosed. And then, between 29 and 30% or so almost 1/3 of patients were still reporting those types of symptoms 12 months after being diagnosed. Pulmonary symptoms, shortness of breath, cough. So 70% of patients reported that initially, 15% still reporting it a year later. Constitutional symptoms, tired, chills, fever, shaking. About a quarter of patients still reporting that a year out. So what this is trying to illustrate is when people are talking about quote unquote long COVID, that there are going to be some patients who are still experiencing symptoms months, maybe even a year later. I think this meme is funny. If you don't want to wear a mask, that's totally on you. That's fine. But, people do well, if you're wearing your mask, why do I need to wear my mask? Well, here you go. So if it's the urine test, if we all run around naked, someone pees on you, you get wet. If you're wearing pants, that's great. You'll still get wet, but you're a little bit better protected. If the person who pees is also wearing pants, you don't get wet. So the idea would be the peer is the person who's got COVID. And if they're wearing a mask, it's better at keeping most of the viral particles inside the mask and not getting on you. Generally, we don't try to culture COVID-19. It is considered biosafety level 3. Viruses are hard to cultivate in general. They are most commonly diagnosed with RT-PCR. That's the way that people are doing the laboratory COVID tests. Generally, if you've done a COVID test, it's unpleasant. They feels like swab your brain, and then they do a PCR, RT-PCR on it in order to determine whether or not you've got viral particles. Some of the other tests can be antibody-related tests, but those are generally not going to be as valid unless it's a little bit late. So the RT-PCR can catch your test pretty early. So this can be done of respiratory or stool samples. So there are some public health agencies that are doing wastewater surveillance. Some of the universities are doing wastewater surveillance. If they start to see increases in COVID-19 in the wastewater, they expect that they'll see increases in case numbers as well. I only have had to do one true COVID test. I've done a couple of at home, like if I had a scratchy throat or whatever, but it was when I was about to have my kids, and I was like, man, I haven't had to have one of these tests. This was September of last year. So I'd gone a whole year and a half without having to have a COVID test because I hadn't been exposed, hadn't experienced any symptoms, and they made me do it before I went to the hospital. And man, my eyes were watering. It was ugly. I didn't like it. So, but that's the best way to do it. Prevention is difficult, as we've seen. You can try to quarantine and screen patients from infected areas. As we have seen in the US, it has been a complete and utter failure. People refuse to wear masks. People refuse to stay home. People are mad about lockdowns, but in countries that have done lockdowns, they've been relatively successful. And again, of course, we've seen in the US a complete collapse of polite society. Vaccination is really one of the best ways to prevent, but of course, we run into a lot of those people who say, well, clearly people are still getting COVID, so vaccines don't work. Well, the idea behind a vaccine may not be that it's going to 100% prevent you from getting the illness, but the vast majority of patients who are vaccinated that still turn up positive for COVID have very mild symptoms. They avoid hospitalization. They avoid dying, which is a pretty good trade-off. A couple of shots and you don't die sounds good to me. A couple of shots, you don't burden the public health system by being stuck in the hospital, have to pay, exorbitant hospital bills. That sounds good to me. So again, the vaccination, especially with the changing virus, all the different variants that have come out, it may not prevent you from getting ill, but it will almost certainly prevent you from having to go to the hospital and die. The vaccines that are licensed for use currently in the United States, there are 2 RNA vaccines by Pfizer and Moderna. They both work in very similar mechanisms. The RNA gets into your cells, not into the nucleus. It gets into your cytoplasm. So if people say, oh, the vaccine gets into your nucleus and changes your DNA, you already know that that's not how RNA works. RNA does not go back into the nucleus and change into DNA unless we're talking about retroviruses, which we're not. So it will make the spike protein, and that spike protein will then, or a piece of the spike protein to prime your immune system to recognize the RNA or the viral spike protein. The Johnson & Johnson is the DNA vaccine. It works in a similar way. The technology for the RNA vaccines is very new comparative to other types of vaccines. And these are the first RNA vaccines that were really on the market were for COVID-19. This DNA vaccine technology, it works similarly to the RNA vaccine technology, but it has been in use longer. For example, the Ebola vaccine is based on a DNA technology. This was put out by Johnson & Johnson. You may have heard that the Johnson & Johnson vaccine is associated with higher risks of blood clots, so this is no longer a recommended vaccine. So, but I got it, but it's one of those survivorship biases. So people say, well, I got COVID and I didn't die, so it's fine. I got the vaccine and I didn't get a blood clot, so it's fine. It's the same thing where I got in a car accident, I didn't die, car accidents are fine, right? You can't say things like that. So if there's an increased risk of adverse complications, things will be pulled from the market. So when people say, we don't know what these vaccines do, they could kill you. The Johnson & Johnson vaccine, higher risk of blood clots, it was pulled from the market. The RNA vaccines have not been pulled from the market, so they're not showing these levels of side effects like the Johnson & Johnson vaccine. And just if you like to be ornery with your family or with people who are science deniers, you can. It's always a little bit fun. The risk of blood clots from the Johnson & Johnson vaccine is about 100-fold less than the risk of blood clots from birth control pills. Just putting that out there. Here's our vaccination rate for Fresno County. I'm actually pretty impressed. 69%. Lower than the national average, but higher than a lot of places in the country. So we're not doing terrible. We could be doing better. There is now an officially licensed antiviral for if you are diagnosed with COVID. It's called Paxlovid. It's a combination therapy. I'm not even going to try to pronounce it, but one of the drugs is a protease inhibitor. The protease is necessary for COVID-19 to release its non-structural proteins. Because it can't release the non-structural proteins, it can't replicate, so this prevents viral replication. The other drug is already on the market. So this top drug, this is new. The second one has been on the market already. It's also a type of protease inhibitor. It's been used in combination therapy for treating HIV and hepatitis C. It is a weak protease inhibitor, so it can kind of have similar activity to the other drug that's part of this Paxlovid. But also what it does is it inhibits one of our enzymes. It's a particular cytochrome. And what this cytochrome does is the cytochrome normally metabolizes drugs that we take. So this second drug, the ritonavir, inhibits the cytochrome, which prevents your body from metabolizing the first drug. If you can't metabolize the first drug, that means it stays in your body longer, attacking the virus. So that's how this Paxlovid works. And if people take it within 4 days of being symptom development, right, of being infected, it can prevent the development of severe symptoms. So if you've been exposed or whatever, 4 days, this will help you a lot. If you take it between 4 and 14 days, it will still help, but you may experience some symptoms, but it should keep you out of the hospital as well. I know recently President Biden was diagnosed with COVID. He's, of course, vaccinated, and he's probably double boosted because he's really old. But I know he's also taking this Paxlovid to help reduce his symptoms.